Good morning, everyone. Hi, I'm Dr. Tarun K. George from Department of Medicine, Unit 4. It's my pleasure to think about the different aspects of how Department of Medicine, or DOM, as you've all heard over the years, has taken on new things. Usually a few consultants or a team, can be at any stage, start off with an interest. They take that interest to want to take some more initiative in either wanting to know more or do more. That initiative kind of forms a niche where actually it might be a part of a service. Those services then goes on to teaching, which then becomes a small specialty within a unit, which may then branch off into a department. And over the years, we've seen medicine actually form this tree, like an evergreen tree. And over these decades, there's been so many departments that have branched off, budded, and moved to different parts of the world and India and the institution. So one such initiative which we're exploring today are initiatives in improving our acute medicine in acute medical care in Department of Medicine. And to present that is Dr. Ronald Albert Benton Carey, who's the professor and head of Medicine Unit 4. Again, a new initiative that we're all novel and privileged to listen to and hear about, share our thoughts and experiences. Ronald has been in DOM and in CMC for many decades now. He's got a wide exposure of interests in medical education, in health policy management. He's been the head of pharmacy services for several years. And he's also been a consultant in the UK in several hospitals, leading services and teaching activities. So it's my pleasure to open the floor to Ronald and looking forward to hear what new initiatives we can all work on together. Thank you, Ronald.
Thank you, Tarun. So the topic today is quality improvement in acute medicine, an introduction. It's going to be mainly about quality improvement, and we'll see how some others can be applied in acute medical care. Now, so I will talk about, give a little orientation about this quality improvement. Then we'll talk about definition of quality, role of leadership, talk a bit about improvement and implementation science, standards in healthcare, and some kind of measuring strategies and how these can be applied in quality improvement methods. Now, when we talk about quality improvement, it's learning to see the forest instead of the tree. We're all dealing with one patient at a time. But you all at one point in time, you may be a leader or a consultant in a unit or a HIU, or where you will have to improve the quality, which means what it means. It will come to that. What we mean by quality, we'll come to that. But learning to see the bigger picture, improving overall quality is important. In general, our training, our department, we all focus on one patient at a time. But the quality cannot depend on one excellent registrar or one excellent consultant. Overall, the quality of the department, quality of the care that we provide has to improve, and we need to set standards for that. So very often when we talk about the quality problem, people will cite lack of resources. Is lack of resources the only problem when it comes to quality? What do you all think? When you think of a problem in quality, what can you think of? Come on, say something. Knowing what to do, okay? So you're saying lack of knowledge, or we all need knowledge. Then come on, a few more responses. Come on, let's make it interactive. Yeah, you can speak loud enough. Yeah. What else can be a problem with quality? Existing systems, Okay, you're like, just we can, just move on with it. Don't ask questions. Okay, so poor quality may be due to the way care is organized. It may be because of the culture of the team regarding quality. We may not be really thinking about quality. For me, this patient matters. I'll do this for this patient. But we need to step back and see what happens to all the patients. If 100 patients come, how many of them get the best care? Those are the questions which we ask in quality improvement. The way resources are used to deliver quality, unwarranted variations. For example, one registrar may ask for a CT scan for somebody with suspected to have a stroke. You might do it in 2 hours. Let's another ask. He gets in 4 hours. Consultant calls, gets done in 5 minutes. Unwanted variation. Did you understand how what I mean? Lack of knowledge. Not all of us may actually understand and mean, understand actually how to manage a certain condition. Lack of data. In general, data collection is less. We collect data only for doing studies, but a good system, a learning system, will have ongoing data collection available for us to constantly improve our system. And of course, lack of expertise regarding quality improvement. We all very experts in doing, in our subject. Like I think by third year, we can manage most of the conditions. We are, see, the confidence level really goes up, isn't it? 6 months you're in medicine, you're reasonably confident. You go to IC 3 months, then you think you can manage the whole world. That's the level confidence. But we need to know about about improving quality as well. We need to understand this. We need to understand healthcare is actually is very dynamic. Hospital is one of the most complex environment in the world. Okay, you know how it is. Just see how the patients struggle to find their ways or to get some things done. It's so difficult. It's well known, not just CMC, any place in the world. A bigger hospital is very complex. It's in constant evolution. Systems which are present last year may not be present this year. It just keeps evolving because we want to do new things, stop old things, and etc. People have differing beliefs and attitudes. I might think of one way how a patient should be treated. Another consultant will think another way. We all know that every unit will have. I remember OG, when you do episiotomy, OG3 you have to go use cotton, OG2 you'll have to use ethylene, and OG1 you'll have to use something else. We all knew that our interns. Every unit we use a different, so different beliefs and attitudes. Providers of care may not have the skills and knowledge to improve care. This actually has become a science in the last 20 years. The quality improvement itself has become a big science. Implementations. These are stuff which we don't actually learn in MBBS or in MD. So just because we become doctor doesn't mean that we will know it automatically. We actually may have to learn it. Okay, and learning how to improve is also difficult given the complexity of the of the system. So how do we define quality? Let me have few responses. When you say I want good quality care, or you say I'm going to give good quality care, what do we mean by that? Okay, what comes to your mind? Let's have some responses. Come on, this should be a. It's okay to say something not right, or it's it's an opinion. Yeah. Proper care at the correct time. Hafiz. What comes to your mind when you think of quality? It's not a test. It's, come on, we're here to learn together. Yeah. Yes, Tangmani. What comes to your mind when it comes to quality? Consultants also, please. Acceptable. Standard of care as per literature. So obviously there are differing ways of seeing it. So there is this Institute of Medicine in the the quality improvement circles. They come up with a come with the concept of what what is meant by quality of healthcare. It's got 6 domains. It's got some 6 domains. I'll show the picture, and it's got some core values. And the whole thing is sort of enveloped by certain ideals, which is transparency, resilience, and leadership. And the whole thing is supposed to be person and kin centered. Okay, that's the picture. Look at this. It has to be, so when you say quality, high quality healthcare, it has to be safe. It has to be effective, which means it has to work. Effective means it has to work. You can't have ineffective stuff. Efficient, it has to happen, at the appropriate time. The same thing, for example, antibiotics, giving antibiotics for sepsis is good, isn't it? But efficient is giving it on time, within 30 minutes, accessible and also timely. No point having a great service and people come and they're not able to access it, or keeping it far away from where the people are. Equity, all people should be able to access it, no matter where they are from, what language they speak, where they're from. They should be the people for whom the service is meant. They should be able to easily access it. And this is a new thing. It has to be environmentally also, it should be friendly. You can't start a new initiative and which affects environment in a not so nice way. Now, there are some core values, which are the central part, which you can see: kindness with compassion, dignity and respect. It has to be holistic. Partnership and co-production, which is the latest thing in quality improvement. You have to also involve the patients, which is not an easy feat. Maybe in Western countries where people are vocal, much more educated, it's a bit easier. Here it may be a bit tough, but that's something which we should aspire for. Now then you have the surrounding thing, which is transparency and resilience, and the whole thing has to be person-centered. Person is the patient, but also the doctor, also the junior doctors, the interns, consultants, other people, the nurses who work. It has to be person-centered. You can't have an excellent care at the expense of the health of of the trainees or the interns or the nurses. All these aspects are important in improving the quality of healthcare. So improvement projects generally should have all these domains addressed, even though one domain may be the dominant focus. For example, let's say you are planning improvement in quality in safety. You also have to think of all the other ones, whether it's equitable, accessible, eco-friendly, efficient. All those things also have to be considered. Similarly, let's say you want to make it more efficient. You have to see whether it's safe. Did you understand? Okay. So in the last 20 years, there has been a lot of talk about quality improvement. Initially, it's about 20 years. We all spoke about NABH standards. If you've been in the hospital, it's we all aspire to become NABH accredited. So their initial thing was all standardization, measuring performance against set standards. Then it moved toward a systems approach. System is where the problem is. That has to be set right. That's true even now. For example, I'll tell you an example of how system-centeredness was used to make care safe. The gases used in operation theater. Oxygen. What's the other one which is used for anesthesia? Nitrous oxide. Okay, the 2 ports. There are patients instead of oxygen, the other gas is given. That mistake has happened. Okay, so what they did, they changed the system in such a way that the port in which oxygen thing goes, they made it in a different format in such a way the other port will not go into this and this port will not go into that. Thereby, the chance of somebody getting nitrous oxide was completely eliminated. Okay, we did a recent exercise in pharmacy where we had. Have you heard of patients taking methotrexate daily instead of once weekly? You heard of it? Okay, even now, even in Australia, it's a big problem in the sense it's a well-known error. So So we had a patient. This patient took daily. What will happen? The bone marrow get wiped out, and then you get neutropenic sepsis, and patient will die. Thankfully, some patients survive, but it's actually just wipes out because it's hits the bone marrow really hard. So we tweaked the system. We made sure that you can't prescribe methotrexate once daily. You might have seen now if you prescribe methotrexate, this comes OD or 1/7. Have you prescribed methotrexate? What comes? 1/7. Now, there's even if you want to prescribe OD, you can't. Suppose if you want to, for some condition they do, you'll have to speak to the consultant and you'll have to change it accordingly. So that is system level change. Whereas let's say I call all the register, talk to them, please don't prescribe methotrexate once daily. Okay, that'll be there for a few months or until you finish, and the new bunch of PGs will come. They won't know what it is, and there comes the problem again, and so on. So we need that's a systems approach. See how we can eliminate some of these problems at the other level of systems. Now it's co-production of health as opposed to management of disease. So how can we join hands with patients in order to improve health? So all three approaches are interdependent and are required to provide high value healthcare. There is this quintuple aim they talk about in providing high quality care, which is improved patient outcomes, improved patient experience, health equity, lower cost of care, improved provider experience. I've already spoken about outcomes, but also patient experience. What is the experience of the patient in the hospital? That's also important. Also improved provider experience. We already spoke about also looking after the staff. Lower costs. No point providing high cost care when you're going to charge excessively. India is one of the worst in terms of health. The out-of-pocket expenses we talk about in general, how much a patient has to spend from his own pocket for health. If you rank it, I think we are 136 or something among the last 10. It's a huge expense. Keep talking about it in the grand rounds, where we need to think about the cost. It's exorbitant. In India, the number two reason why a family above poverty line goes below poverty line is admission to a hospital. 2 weeks of UTI, meropenem, how much? Bill. Let's say 2 weeks admission for a complicated UTI. How much is the bill? 1.5 lakhs? 1 lakh? More than that? Suppose polymyxin is even more. Yeah. How much? 1 lakh? 1 lakh is a reasonable bill. How much will an auto driver earn? 20,000 per month? 5 months is salary. I can't afford. I'm telling you, my bank balance is not much. Okay, so think about the all aspects of the healthcare of quality. There is a role for leadership and policy, which is the leader should create a common purpose. Zero ICU admissions from wards is a good purpose for us to talk about. There should be no patient who should be surprised and go into ICU. We need to put in systems to make sure such things don't happen. Or zero hospital acquired infections. So there is a role for leadership. Just as one slide, I know it's not the most important slide, but the leaders also have to play, policy has to play a role. We need to enhance a sense of belonging. We need to use data to allow prediction and anticipation of future performance. We need to empower people to make decisions and be in control. And a culture of learning has to be created in the workplace. So leaders, you will be all leaders in a unit. Or if you go to a bond hospital, you may be the only consultant looking after an entire department. You do have a big role in improving quality. I'll talk a few things about improvement science. There's something called improvement science and implementation science. It's not easy to improve things. It's very naive to think that things can be improved, just like that. Okay, so people have looked at it very closely, and how can we improve the quality of care? Okay, so there are some models and theories. This is one such. It's called this Donabedian theory. Just look at the picture. So there is the structure, and we need to look at the process, and we need to look at the outcome. So when we want to improve, first we need to look at the structure, set up the right structure, which will lead on to the right process, which will lead on to the right outcomes. So any process, if you want to analyze, you can use this model to analyze. 60-year-old man came to ED with symptoms of TIA. ED was crowded. He had to wait for 6 hours. Security guard was rude to them. He left with the family, or he felt, I'm okay, just a TIA. He left with the family. The next day, he developed a full-blown stroke. What's the problem? Use this model to see that. Structure is crowded. Yeah. What about the process? There is security guard was rude. He didn't tell them what to do. Maybe there could have been a follow-up clinic. Maybe he could have told, they could have explained, you're going to wait. There was no clear process. And obviously the outcome was bad here. This is just one example, artificially created, but you can think of other things where structures and processes can lead on to adverse outcomes. Then there is, as you know, this Juran trilogy. It's not a novel, it's a concept. Okay. To improve, one needs a guiding principle that would be the basis for improvement. So we need to plan for quality. We need to establish controls for measurement, and there's a need for feedback loop for learning. All improvement consists of a series of projects that need to fit into a common purpose. For example, too many emergency calls at night. We need to study the calls. We need to find that if you study, you might find that jobs are not being handed over at night. Too many surprise calls, insulin not written, IV fluid is not written, sudden hypokalemia not corrected, and so on and on. You could do a quality improvement project. It might land in maybe a night handover meeting where the jobs are being handed over. You may be able to document that the number of calls are coming down. And if you document mortality or admission to ICU, it may show that that's improving as well. Then there is this concept called the lenses of profound knowledge, which is proposed by this man called William Deming. We need to look at these problems with 4 lenses. One is the appreciation for a system. If you want to improve any system, you need to know the system in and out. You need to appreciate what's happening. Okay, so I'll come to an example. We need to know we need to have a knowledge about variation. Like, what is the variation? 4 hours, 2 hours, 3 hours. We spoke about ordering a CT scan. We need to know about the variation. We also need to know the psychology of people who are involved, the interns and the consultants, the nurses. What are they thinking about this problem? And we need to have a theory about of this knowledge. Okay. Let's think about this one. You want to reduce time to start antibiotics for sepsis. We need to know, okay, where do the patients come? They come to ED, they are diagnosed as sepsis. Who diagnoses? How is it diagnosed? What happens then? When is the TC sent? When is the blood culture sent? We need to appreciate the system. We need to know the variation. What is the variation in the time of taking blood cultures, of starting antibiotics? We need data. Then we also have to have a theory about the knowledge. What do people think about what sepsis is? About what they think when the antibiotic should be started. Some people might think, I think it's okay to start a bit later, nothing will happen. They may not really know that it has to happen within 1 hour, within 30 minutes. Okay. Then also the psychology. Are people involved stressed out? Do they have fatigue? Or do they have cognitive biases? All those things need to be looked at. So this lenses of profound knowledge is actually used quite a bit in making improvement changes. So that's improvement science. Then there is implementation science. This is scientific. So this has both improvement science and implementation science has drawn concepts from psychology, epidemiology, behavioral sciences, etc., etc. And it's like a sort of a mishmash to improve implementation. Okay. So this is a scientific study of methods to promote uptake of research findings and other evidence-based practice into routine practice in order to improve quality. Is hand hygiene important? How many of you think hand hygiene is important? Can I have a show of hands? Fantastic. Okay. How many of you think poor hand hygiene increases mortality? Fantastic. Do you know what's the hand hygiene rate in Department of General Medicine? Just take a guess. Not the consultant, PGs. You might have seen the email. What's the percentage? Hand hygiene. Just take a number, the one number. Percentage. Hand hygiene, compliance. I'll see. Sorry? 30%? 40? Very optimal, very optimistic. 40, it's 25 across all the units. Yes. So hand hygiene is important. It increases mortality, and you still don't do it. Not you, I should say we. Okay, all of us. Even I think consultants did fairly okay, 40, 50%. PGs are 25%. That's the point of implement. So you want to improve hand hygiene. You want to do something to improve hand hygiene. You all know it, but we won't do it. You see, that's the point of implementation science. Okay. There are many frameworks. I'll just tell you about one framework. It's a quality implementation framework. There's phase 1, phase 2, phase 3, phase 4. Suppose you want to improve hand hygiene, we need to engage, we need to understand our system, and we need to plan. Okay. We need to go to the ward, I-ward, and see where is the chart kept? Where is the hand rub kept? How many are there? Who orders it? What happens when the patient leaves? What happens when you come to the computer? Do you do that? We need to understand the system. Okay. Then we need to build capacity within the system. We need to see whether we think about any other way. Now the nurse has to give a prescription to the patient. They have to go by and come back, and it's placed. Can we think of any other methods? Maybe should we use ward supply? Should the sisters be in charge of keeping it? Those are the things which we need to improve capacity. Maybe the interns need training. All that we need to look at. Interns need training, consultant need training, the nurse needs to know the importance. We need to work maybe on a trolley to keep all the charts so that we don't keep putting our hands. Maybe grand rounds, the number of people go for grand rounds should come down. 25 people, and we all happily lean, and we actually end up palpating all the beds and pass on to the next patient. Is it not true? And we pass on CROs and MRSAs and whatnot, everything. I'm telling you, these days we are increasingly seeing patients who die of CRO, where their hands are tied, they can't afford, and they're left to die. Happens where patients are dying because, so that's the problem in quality. We can improve that actually. Then you implement. So you think about strategies, implement, and then you learn from it, embed it. If it's good, embed it in your system, make sure it's sustained. There is also standards in healthcare which we need. So standards, have you heard of ISO? ISO, that is non-medical, but obviously even in medicine we have standards. So standards help processes to reach a certain level of quality and ensure safety, usually developed by experts. So measured by guidelines, external evaluation, regulation, accreditation. So we have NABH standards, huge thing. They give us a list. I think it's done very good to a lot of hospitals in India. Definitely it's helped CMC. We have NABH standards. Overall, I've been here as a student as well as staff now. I know how things have improved over time. NABH really has helped. Setting standards. That's a standard. This is what we should aim for. But we could have internal standards also, where we can have clinical guidelines and pathways. We all refer to guidelines, usually like maybe an US-based guidelines or NICE guidelines or one of those. But sometimes we do refer to Indian guidelines. Some departments have your own guidelines. That's a good start. There is also, this clinical care pathways. That's a slightly it's slightly better than having a guideline. You make the guideline specific for your context. So what is done is a complex intervention for the it is a complex intervention for the mutual decision making and organizational care processes for a well-defined group of patients during a well-defined period. So that's the clinical care pathway. If you if you work in a Western country, UK and US, it's a very common thing. I'm sure that Tarun would have noticed. They will have pathways for some of the things. For example, let's say you do a biopsy, okay? You do a gastroscopy, and the biopsy is sent, and biopsy shows cancer, okay? When will you know it's cancer? Let's say patient comes to you, loss of weight, loss of appetite, you've done a gastroscopy, and you ask them to come after 1 week, they're coming to you. You have to follow the results, isn't it? Now, the hospital where I work, they had a pathway. The moment they found it cancer, it's set off a pathway in which it is informed to the oncology nurse, who will call, set up a meeting. MDT was arranged. It happened much quicker than it just depends on one person. But the people knew there was a pathway, and people knew what needs to be done. So it was available in the system. I'll show you an example of another pathway for acute pulmonary embolism. So this pathway has an explicit statement of goals and has key elements of care. It facilitates communication among team members and with patients and families. It helps in coordination of the care process. It also specifies documentation, monitoring, and evaluation of variances and outcomes, and also helps in identification of appropriate resources. It all sounds a bit very non-medical, isn't it? But remember, it all helps in outcomes. At the end of the day, patient want good outcome. We can't shy away from all this. Okay. So the purpose is to translate guidelines into local context, specify specific steps in care with a specific time frame. For example, a pathway for sepsis should say within 1 hour, the ED doctor has to give the antibiotic, not just give antibiotic. That's a bit vague. Within 1 hour, very time specific. With who? The ED doctor, not the medicine registrar, who might see the patient after 2 hours for all you know. So specifies clearly. For example, let's say we say a meningitis pathway, it might specify the medicine doctor in casualty has to do the lumbar puncture, not sent off to the doctor in the ward. Or we could say it need not be done with the ED doctor. It can be done in the ward if it's not very urgent. So things are very clearly specified with the time frame. This is a pulmonary embolism pathway where it clearly talks about when a patient comes, what all needs to be done. FBC, UNE, LFT, screening, etc., well score, D-dimer, what needs to be done. The whole thing is specified, and this is easily accessible for anybody who is seeing. It talks about what should be done for somebody who is pregnant, what kind of investigation should be done. If it's normal scan, what should be done? Where should they be referred? It even has a patient transfer information. Suppose you want to send the patient to, let's say, an OPD. Here it's ambulatory care, they call it. It has a model, a form that also is specified. Okay, so that is an example of a clinical care pathway. Obviously, it cannot be done by a registrar. It has to be done at the level of leadership, okay, at the unit level, which is what we see happening. We do have guidelines. Pathway goes a bit beyond that. Specifies, it talks to other departments, units involved, comes to a consensus and say, this is the common terms that we work with. There are many strategies for measurement, and measurement is actually foundation, okay? We need a robust plan for what to measure and how to measure. There are two things commonly used in this quality improvement, which one is called time series analysis. Other thing is statistical process control. I'll show you an example. In general, a range of methods is preferred and not just one or two outcomes. There's quote by this person who says, without data, you're just another person with an opinion. You might say, oh, this is great. But with data, you have more credibility. You can say that this is how it should be done because it improves outcomes. So this is statistical process control, where let's say this is month 1, you see, I told you there is variation. Think of this as, let's say, think of something like an readmission rates or whatever. Okay, we are concerned that a lot of patients who are getting discharged from medical wards getting readmitted. So you start plotting, and there is some variation. Month 1, there is 35. Then month 4, it's month 2, it goes down, goes up and down. And then it seems to go up in month 16. Then you implement an intervention. Then you document that actually the readmission rates are coming down. This is a statistical process control chart, very commonly used. So with all this knowledge, we need to apply this to quality improvement projects, which could be small based on how you're doing. It's very common for in other healthcare system, it's common for PGs to undertake quality improvement projects, PGs and interns. Think of some problem where, for example, let's say you come to Medicine 4 and you notice that hand hygiene is a problem. Okay, so you can actually work on a quality improvement project and make a full plan, and you can finally end up with this statistical process control chart, and you can document improvement and think about how that can be embedded into the general way things work. So we need to identify and define the problem. We need to map the process, analyze the process, involve and engage staff. You alone can't do it. You may be the best registrar, but you can't improve control if other people involved in the process are not involved as stakeholders. Preferable to involve patients as well. That's a difficult task in our setting. We need to write a problem statement after we understand the problem. I'll give you an example. Example of a problem statement. Despite the importance of timely ECG interpretation for ACS patients, our ED has observed door to ECG times exceeding 15 minutes in 30% of cases, potentially delaying diagnosis and treatment. When would somebody comes with ECG, comes with acute chest pain, how soon do you need an ECG? How soon? Yes, Nishit. As soon as possible. How soon? 1 hour? No? That's the standard which you'll have to set. Okay? We can look at the data and say, well, how soon? As soon as possible is what? For some people, that might mean 45 minutes. But we can set a standard and say, within 5 minutes. Okay? Within 5 minutes, an ECG is done. So you say that's the problem statement. Okay? So obviously you need data. You need to look at patient, the chart, which the sheet that is stuck on the chart on the left side, ED. You can look at what patient, what time they come in. Then look at the ECG time. It's a good, quality improvement project for, somebody wanting to do this. You can say, well, this is the time, 10 patient comes, 10:40 ECG happens, 40 minutes. Then you diagnose, yeah, you already lost 40 minutes of your time. Did you understand? So that's the problem statement. Then you do a process mapping, analyze the problem. For example, we can ask the question, why does it take 40 minutes for an ECG? There are so many methods. One easy method is 5 whys, which you can do in your death audits when you do in your departments. You can ask 5 whys. The patient died of hyperkalemia. First why is, why did the patient die of hyperkalemia? Okay, then you get an answer. Ask another why, and keep asking 5 times. You usually have an answer. Okay, until you stop. That is just one. Then there is something called a fishbone diagram, which I'll show you an example, where you can actually draw the outcome in the end and look at all the processes, people, processes, ED, medicine registrar, all that. You can say, where is the problem? Often it's got more than one reason. There is also this Pareto diagram. Have you heard of this Pareto rule? 80-20, 80%, 20%. So 80% of causes, 80% of chest pain cases will be usually due to about 20% of the causes. Okay, there may be an 80% which will cause 20%. Basically, a small number of items which will cause majority of the problems. So if you focus on that, you are sorting out majority of the problems. Do you understand? But you need to know what the small list of problems are. That's an example of a fish bone diagram. if you're late for work, you can actually look at the whole thing, the process, equipment, materials, people, environment, and see what is that which makes you come late for work. Okay, this is the example of Pareto chart. It's a good way to identify the best opportunities for improvement because we can't focus on smaller, insignificant ones. We want to put our money where it will make a difference. Okay. We need to set a name and develop a theory. For example, you say, you have to come up with a hypothesis. The reason why the ECG is getting delayed is because of this. Then you need to write an aim statement using the SMART thing. I won't go into that. You all know what the SMART things are. Using that, you do something called a driver diagram. That's just one method, but there are other methods which you can go and read for yourself. This is a driver diagram. Look at the first box. I'll read it for you. It's a bit small. 80% of patients with diabetes and uncontrolled hypertension in one GP practice will have a reduction in blood pressure and an increased understanding of hypertension and its treatment. So that's the aim statement. Okay, it's smart, specific. Okay, it can be measured. Okay. Then this is little thing here. This called this called a primary driver, and this called the secondary driver. So here they've written primary drivers as improve patients concordance to medication, increase patient self-management, provide access to specialist care in the community, identify all patients with type 2 diabetes and hypertension. Then you have secondary drivers to push this this primary driver. Okay. For that, you have some change ideas, and each of this can be implemented in the change program, which is the next step, which is the PDSA cycle, which is plan, do, act, study. Anyone has done audits in the department? As interns, some interns have done audits. Have you done audits? Looking at no one has done? Okay, some interns might have done. We do have audit requests now and then, especially from interns. They all have gone for bond, I think. Okay, so audit is just doing once. Okay, just collecting one data. This is basically, you do an audit, look at the problem, then you make a change, and then you do an audit again and show that it's improved. And then again, you come up with the next one. Then you do so this cycle keeps improving. So it's a cycle of improvement going on and on. Okay. So plan is ask yourself who, what, why, and how. The ECG I told you, think about that, how and why this is happening. Then think about a change. Maybe chest pain, it doesn't comes, let's say the change is a nurse who is in the triage, she should do the ECG. Okay, so to give an example. That may be the change. And then you see the next time change after implementing it. You see, okay, now what is the change? How soon does the ECG gets done? That's the outcome which you're looking at. Okay, let's say from 40 minutes, it's come down to 20 minutes. Then you think about another, okay, well, this has happened, but still there's another problem. Then you keep doing it. That's a PDSA cycle. So most of these quality improvement projects, especially certainly at the small level, use this cycle, which you can do in your own departments, in your units, even your personal life, you can do it. In fact, you do PDSA cycles as doctors in smaller level. Let's say patient comes with uncontrolled, let's say uncontrolled hypertension. Okay. And you check the BP. Okay, that is the planning. And you're going to implement, which is starting a new antihypertensive medication. And you ask them to come up with a BP chart for next 2 weeks. They come to you and you're going to study the BP data. And then based on the BP data, you might do the next change, which is basically go up or down on the antihypertensive medication. Now, just imagine doing the same thing in your ward for the problem that you have identified. Okay, that's a PDSA cycle. So then, of course, document and share what you have learned so that not just your good practice is just not with you, but you also share with other departments and it becomes, infectious. So this is just 2 slides. What, in acute medical care that we do, what can be done. We need more data. We need to look at structures, processes, and related to outcomes. We need a culture of quality improvement and safety. We need internal standards, clinical pathways. We need to compare with external standards. I'll show you an external standard for acute medical units by the Society for Acute Medicine in the UK. All patients admitted in acute medical unit should have an early warning score. So that's the standard there. Everybody gets, it's part of the national program, so everybody gets, that's an important quality marker for them, because that helps them, identify at what level the patient should be treated. A new score of more than 10, the patient should be seen by an ICU consultant, or somebody 0, he need not go and occupy patient, in the center bed, and so on. So that really helps efficient use of resources. All patients should be seen by a competent clinical decision maker within 4 hours of arrival on the AMU. It's usually at a level of a senior registrar or a consultant. Consultant physician should see the patient within 14 hours. So those are the standards, which is about 5 years old. It might have changed. Then data collection, mortality rates, who are discharged directly from acute medical units, readmission rates. That will help us to see what is our quality. So that's the comparison with an external standard. Then we have PDSA cycles, which I told you, which we need to look at, because 80 to 90% of our patients are acute admissions, isn't it? In your ward, 80% easily comes through, 90% maybe. They all come emergency. That's our bread and butter. You want to improve quality, we need to pick out and see how we can improve quality management of TB, OP poisoning, snake bite. We can look at and improve quality each one and one. There are something which will encompass the whole thing, but something which we can specifically, for example, obstetric medicine, what they've done. It's in general, you can say that's a quality improvement project. Those days, it took a long time for somebody from, for them to call for a consultant, for some consultant to see. The process was quite big. Now it's all been streamlined, so quality of obstetric medicine treatment has improved. You can say it's a big quality improvement project which has been done. I'll summarize what I said. When I talk about quality, we're talking about multiple domains. I showed you the picture: safety, equity, person-centric, core values, kindness, compassion, person-centric. Okay. Think of when you see a problem, look at the structure, process, outcome. Think of the this Donabedian model. Think of that Duran trilogy, which said all improvement is a series of projects. Lenses of profound knowledge. We need to look at the system, theory of knowledge, variation, psychology of people involved, implementation science. I spoke about quality implementation framework. Standards are needed, external and internal. Measurement. We need data. We need to think of strategies how to measure. There are some things which can be measured. We'll have to invest some, of course. But if we have data, real time how we are doing and how we can improve things. And lastly, doing it. We spoke about quality improvement project, which is defining the problem, writing aim, process mapping, making a driver diagram, and also doing the PDSA cycles. That's it. I hope you all are introduced into a new idea of quality improvement, which is not part of your curriculum, but you all will be doing it in big scale in the coming years. I think this is the future. People are going to look at data in the era of internet and social media and things like that. Thank you. I'll end there.
Thank you, Ronald. The floor is open to registrars and consultants for thoughts, comments, and questions. So again, an interesting area of quality, implementation, and improvement. I'm sure it's something that's happening at every unit, within every team, and the department and the institution. So any questions or comments? You can also share any experiences you all have had as registrars or even consultants of how you've improved the system for yourself at a small level. Maybe it's follow-up of your patients, your outpatient services.
Come on.
I'm going to stretch the consultants to think a bit and then come down to the registrars. could be in different settings as well, whether it's in the main hospital, in Chittoor, in a similar smaller hospital where you work. And I think that's very important, because when you realize that this is all theory, you're intuitively actually doing this in a lot of smaller settings. And if you're going to be working in a secondary hospital, this is a very central aspect of the kind of practice that we need to engage in. Yeah.
What I was thinking about and wanted to ask you, sir, is that when we come across problems, let's say within there's a problem in the system during my course, and as a PG, you recognize the problem, but you probably don't have any time to give any thought about how to address it. So maybe I'm not aware of it, but is there a structure in case where if we identify problems, how to escalate it, or how a PG can escalate it? Of course, there is the system. Okay, there is a consultant, a senior consultant, and the head of unit. But is there something in place for the Department of Medicine specifically looking at quality improvement? As to when we identify a problem, how do we go about making a plan for it?
So that's why I actually spoke about having a culture. If there's a culture of quality improvement and safety, it'll be like everybody will be open to, yes, that's a problem, let's do something about it. But I don't know, I can't clearly say whether we have a culture of quality improvement. I don't think so. So which is what we need to work towards. In general, I think the units should be, consultants and the heads should be open about how can we improve quality. For example, a PG or a consultant should not, junior consultant should not hesitate to have a chat. So this is the problem. Can we do something about it? Okay, let's work on a quality improvement project. Let's do this, let's do that. There are some things which you can do, something which you can say, well, that's something we have already few other projects, we may not be able to do this, but that's something which we can do later. That conversation has to happen. So it's not very clear cut, isn't it? That there is, for example, let's say it's easy to say one consultant will in charge of quality improvement. Everybody go and tell him. You think he'll improve things? You'll have to do a quality improvement project to see whether that will, but it will not. That's not a culture. Just one person, because 5 units or many other departments involved, not yet a culture. So hopefully that will come, but that's something for all of you to think and keep in mind wherever you are. Make sure there's a culture of quality improvement, that we are open to improve things, and we're open to collect data, open to being transparent and so on. I hope it answered the question, Janavi.
Any other thoughts or comments?
Amita has said something.
I know you gave some next steps, sir, but I was wondering, what is the immediate step? I thought about when you said data collection. It sounds like it's difficult to collect data without setting some standards about what are the important things that should be done in a certain time. At the same time, to do that, you need to either make some consensus internal standards or apply an external standard, which itself is a process. So is that the first step, setting the standard for ourselves, and then you have to collect data according to it? Would that be the next 2 steps, or what would you recommend?
The broader thing could be, if there is a set standard which is already in place, easy to fall back, where actually, if we can't develop our own standard, it's easy to fall back on a national established, standard. For example, the surviving sepsis, we didn't come up with it, but we still follow it. There are some established standards like that. For individual, clinical conditions, it may be better that we have our own, our own pathways, which units have to come up with. It's not easy. You see, that's why it's quite, because too many stakeholders, too many problems. So we need to work one by one. There are some things which are across the unit, but some things we'll have to work one by one, which, let's say in medicine 1, let's say, for them, it's easy for them to come up with toxicology, snake bite, clinical pathway. Okay, what should be done? Communicated across. Everybody agrees on certain timing. That pathway can be followed across all the units. So first is to study what you want to improve. see everything as a, as a quality improvement project. We can't do everything, but we can actually take one and do it. One aspect that bothers you. Janavi said she saw something and we want to do something. Think about that. What is that? What is that, problem which you have identified, and how we can work on to improve the, improve the quality.
Great comments. Any thoughts from the others? We're just realizing that as we were talking through things, even a simple thought like our patients who are discharged from the ward, are we ensuring that they actually have an appointment when they come back to OPD? And we don't have a checkpoint to ensure that they're not leaving the ward without that very important follow-up. So there are probably such small aspects, either which is very operational or very clinical. It happens at the level of the interns, registrars. Consultants are sometimes unaware of it. But how do you create a culture that, one, we learn or we talk about it within the unit, but we also learn from other units? And I think that's really the strength of DOM and CMC, where we can cross-pollinate ideas and solutions. Part of this is actually going back and looking at our old audits itself. What are the audits that our interns have been doing, that the registrars have been doing? How have this translated into? And this actually leads to another side of operations quality improvement, which is probably a project that a junior consultant can actually be interested in taking forward. So these are all initiatives. It's the opportunity here is to lay the foundation, start the conversation, and see where things go.
I'll just give you one example of what Amita said. We had a problem there was a cardiac arrest in the ward, and they called the CAR team. The patient already had a DNI, so CAR team was called, and CAR team came rushing, and they were told, well, this is DNR. They were a bit, obviously is not the right thing to do, isn't it? Then it was pointed to us that there's been lack of communication between the doctors and the nurse, because the nurse is the one who activated CAR team. What should we do? So lack of communication between. So we thought of an idea. Okay, we didn't do as a quality improvement project, but then we had to think, how can we improve communication? If you were actually to do a fishbone, you'll find out that the nurses did not know what the problem was, because there's no problem sheet in the chart, no progress note in the chart. It was in the pad with the PG registrar. The nurse did not have access to clinical workstation. We can look at all that. Okay, so what we did, we started one meeting called care coordination meeting, where the doctors at the end of the rounds, they'll tell the nurses, just go through the list of patients quickly and tell them, this is the plan, this is it, this is what it's planned to do. DNR not for intubation. So the nurse obviously will tell her team, hopefully. So think of one problem and see what we can improve, and see whether that's making a difference in the outcome. No further questions?
Thank you, everyone.
I'm open for conversation. Come and have a chat, anytime. And if you are wanting to do a quality improvement project, M4 is welcome. Okay, I think it's an exciting thing to do. It's not like a standard study. It's slightly different from how we do like a cross-sectional study or whatever. This is a quality improvement study. Something that bothers you, you want to do something, let's work on it. Thank you.